Hi, my name's Joseph Shaw, and I'm a third-year internal medicine resident at the Ottawa Hospital. I've been doing thrombosis research there for a few years now in association with Dr. Lena Castellucci and Dr. Mark Carrier. And today I'll be presenting my poster on thrombotic complication rates following anticoagulation reversal. And this is a retrospective evaluation of prothrombin complex concentrates. So as you all probably know, the effective reversal of anticoagulants for life-threatening bleeding and for emergent procedures can be challenging. Vitamin K antagonists can be reversed through the use of both prothrombin complex concentrates and vitamin K, and there is quite a bit of evidence that supports the use of these agents for reversal. However, when it comes to reversing direct oral anticoagulants, the situation is a bit more challenging. Praxbind or idarosizumab has recently been approved for the specific reversal of dabigatran. However, there is still no approved specific agent for the reversal of direct 10A inhibitors such as rivaroxaban and apixaban. There have been a few agents such as factor VIII inhibitor bypassing activity, which is an activated prothrombin complex concentrate, that have been proposed as potential reversal agents for the direct oral anticoagulants. However, it is important to keep in mind that the evidence supporting the use of these agents is fairly limited. At present, the evidence is limited to ex vivo or in vitro laboratory studies, as well as quite a few case reports and a small case series. In fact, recently there was a small prospective cohort study that was recently published in Thrombosis research by Dr. Schulman that showed that APCCs or FIBA might potentially be used to control DOAC-associated life-threatening bleeding, but most of this evidence is not in live humans with active bleeding. It's usually in animal models or, as mentioned, laboratory data. Now, the issue with the use of prothrombin complex concentrates or activated PCCs such as FIBA is that there's a concern regarding the potential for thromboembolic complications. There is quite a bit of evidence supporting the risk of thrombotic complications using PCC for warfarin reversal, as well as the use of APCCs. And therefore, there is a legitimate concern that the use of these agents may be associated with thrombotic events after their use for anticoagulation reversal. So the overall objective of this study was to describe the clinical outcomes following the use of PCC for VKA reversal and also APCC for DOAC reversal in situations of life-threatening bleeding or needing emergent surgery. So this was a retrospective chart review that was performed on consecutive patients receiving either APCC for DOAC reversal or PCC for VKA reversal. And this was done at the Ottawa Hospital. The patients were evaluated between January and June of 2014. The PCC that is usually used at the Ottawa Hospital is Octaplex or Beriplex, whereas the APCC is, as mentioned previously, FIBA. And our main outcomes for this study were looking at thrombotic complication rates as well as associated mortality, and these outcomes were evaluated up to 30 days post-PCC administration. Now, in terms of the results, first I'll be focusing on the VKA reversal using prothrombin complex concentrate. So in this cohort, there were a total of 194 patients who received PCC for reversal of warfarin anticoagulation. So the main VKA that we tend to use in Canada is warfarin. It's used almost exclusively. And I just want to focus in on table 1 here, the column on the right. I'll be coming back to the APCC cohort on the left here. But as you can see, the age of the PCC cohort was 76.3. So this is quite elevated, but it's consistent with other small studies looking at warfarin reversal. These tend to be patients who are on warfarin for atrial fibrillation, for example, and they do tend to be older patients who are at risk of bleeding. The other thing that I do want to highlight is that the mean CHADS-2 score was 2.5, so these are still patients who are at somewhat high risk of thrombotic complications such as stroke or recurrent VTE. Now, the patients who received PCC for VKA reversal were on the warfarin for either atrial fibrillation or VTE. There were also a minority of patients who were on the warfarin for mechanical valves or other indications. And as you can see at the bottom here, PCC was given for both major bleeding, so patients presenting, for example, with GI bleeding or intracranial hemorrhage, and also PCC was given for preoperative reversal. So these are patients who were on therapeutic anticoagulation and needed urgent surgery, such as laparotomy, for example, and needed their anticoagulation reversed in order to proceed to surgery. The PCC dosing ranged from 1,000 units to 2,500, and these are the dosing that's usually done in Canada is weight-based, and these doses are fairly common for what's usually used for VKA reversal. Now, in terms of the main outcomes, so the 30-day thromboembolic complication rate for the use of PCCs was 5.2%. Now, that corresponds to 10 thrombotic events. There were 4 DVTs, 2 MIs, 2 TIAs, and 2 strokes. This percentage is somewhat consistent with other studies that are being done recently. Although, as mentioned, the systematic review done by Dentali et al. Showed that overall there's approximately a 1% risk of thrombotic events when you reverse warfarin with PCCs. The 38-day overall mortality was quite high at 16.0%, corresponding to 31 deaths. And obviously, in this setting, we care more about the fatal bleeding and fatal thromboembolic events, of which there were 8 and 2 respectively. Now, the 2 fatal thromboembolic events, they were actually 2 fatal NSTEMIs occurring. One of them occurred 2 days following PCC administration, and the other one occurred 8 days following PCC administration. One of these patients did have known prior significant coronary artery disease, but the mechanism of death, and one of the patients, they developed the NSTEMI and then developed an arrhythmia, and subsequently a code blue was called, for which they then subsequently passed away. And the other patient then developed progressive heart failure following the NSTEMI and passed away shortly thereafter. So now I'll be focusing on the APCC DOAC cohort. So that is the patients on DOACs who received FIBA for reversal. Now, this is a fairly small cohort because this was early on in our institution when APCC was just starting to be used for DOAC reversal. So a total of 11 patients, 3 of whom were on dabigatran anticoagulation, 5 were on rivaroxaban, and 3 were on apixaban. So we have fairly good representation of the 3 main DOACs that are commonly used in Canada. The APCC dosing range was quite wide. The dosing algorithm that we use in Canada is mainly weight-based. And then just focusing on the outcomes, the 30-day thromboembolic complication rate was 9.1%, which is higher than what we found for the PCC cohort. However, it is important to keep in mind that this is a very small cohort, so this is 11 patients overall. So this 9.1% actually only represents a single patient who experienced a TIA within hours of APCC administration. So this event was fairly well documented. So as I mentioned, this is a chart review, and there was good documentation that once the FIBA was done being infused, approximately 30 minutes later, the patient who had no known prior focal neurological deficits, they developed transient aphasia, which lasted for about 2 hours. A stroke code was called, and the patient had an urgent CT head done, as well as a CT angiogram, neither of which demonstrated focal ischemic changes. And as mentioned, the deficit disappeared approximately 2 hours after onset. So the patient was diagnosed with a TIA. Now, moving on to the overall mortality, again, the 30-day overall mortality rate was quite high at 36.4%, although, again, this is a small cohort, so this represents only 4 deaths. There were 2 fatal bleeding events, which I'll highlight in just a second, and importantly, there were no fatal thromboembolic events, so obviously that one TIA that I highlighted earlier was not fatal. If we focus in on table 3 here, just to focus on the DOAC patients, so this is a detailed overview of all the patients who received FIBA for DOAC reversal. And as you can see, there's this one patient here who experienced the TIA. They had a CHADS-2 score of 2, so at moderate risk of having thrombotic events. However, as mentioned, this TIA did occur shortly after the FIBA was infused. And then, as mentioned previously, there were 2 patients who passed away from major bleeding. One of the patients was an elderly female who had experienced a subdural hematoma and was made palliative shortly after the bleeding was diagnosed and after the FIBA was given. And the other patient died of major bleeding as well as sepsis, and this was an upper GI bleed, again in a fairly elderly patient. The EGD was performed, but there were no therapeutic interventions performed during the procedure to attempt and stop the bleeding. And this table 4 just provides a bit more details about the patients who received FIBA for pre-procedural reversal. And as you can see here, there were absolutely no complications at all. It's a fairly small number of patients, but all of the procedures were completed without any concerns regarding hemostasis, and all patients survived hospitalization. It is important to mention that these procedures that we're highlighting are all major procedures, so major orthopedic or even general surgical procedures. The main conclusions of this study are that it does appear that the administration of a PCC for DOAC reversal appears to be associated with a relatively similar thromboembolic complication rate as compared to PCC administration for warfarin reversal. Now, there are some important limitations to this study. Obviously, it is a retrospective study, and therefore the data is only going to be as accurate as what was recorded in the charts. In addition to that, there's no form of matching for these 2 cohorts, so it's important to keep in mind that these are 2 different populations, and therefore there could be numerous confounding factors involved. But we do think that due to the lack of evidence surrounding the use of APCCs for DOAC reversal, we do think that this is overall useful to show a rough comparison between PCC for VKA reversal and FIBA for DOAC reversal. And it at least shows that there's not an extremely high thromboembolic complication rate when FIBA is used in these emergency situations. But overall, the take-home point from this is that large prospective studies are required to confirm these findings and to show for sure whether or not FIBA is effective for controlling these bleeding situations. So overall, I just want to say a special thanks to the physicians, nurses, and staff at the Ottawa Hospital as well as the Ottawa Blood Disease Centre. In particular, I want to thank Dr. Lena Castellucci and Dr. Mark Carrier, both of whom have been very supportive of my research over the past 5 or 6 years. So a special thanks to them. Thank you.